Thank you very much for your kind introduction. Now, I would like to introduce spinal balloon adhesiolysis and decompression using the Jin Woo catheter. There are plenty of non-surgical interventional treatment for spinal stenosis. However, there isn't any actual procedure that directly alleviates stenosis of the spinal canal and intervertebral foramen. So I devised the balloon decompression procedure and designed the clinical trial to verify its effect. Claudication is a major symptom of spinal stenosis, which is caused by venous congestion due to more than 2 levels of stenosis. My hypothesis was that the claudication would be improved or alleviated if the circulation could be improved, even just a little by relieving either one of the 2 levels of stenosis. So I devised a new procedure called transforaminal balloon decompression. The study on its effect was published in Pain Physician in 2013. Among patients with less than 2 levels of foraminal stenosis and unilateral neurogenic claudication. This trial included only those showing none or minimal response to other non-surgical interventions. I randomly assigned patients into 2 groups. With the balloon group, I inserted the balloon catheter into the intervertebral foramen and performed the balloon decompression. With the sham group, I inserted the balloon catheter into the intervertebral foramen, but did not perform balloon decompression. In other words, except for carrying out the balloon inflation, other factors were the same for both groups. The needle was inserted the same way as a transforaminal epidural block. This part, from this point to here, is the area of intervertebral foramen. Decompression was achieved through reparative ballooning and deballooning the whole intervertebral foramen area, while slowly withdrawing the catheter. The leg pain, back pain, ODI, and claudication significantly improved over the 3 to 4 months in the balloon group compared to the sham. Significant improvement in claudication led to higher levels of patient satisfaction. One year after the procedure, 18.8% of patients in the balloon group showed more than 50% of pain relief, whereas in the sham group, none has been recorded. In order to confirm whether these improvements were actually made through the dilation of the marginal stenotic area, and if so, how much it actually dilates, I injected contrast dye transforaminally before and after the balloon decompression and reconstructed the spread pattern into a 3D image. As you can see in this image, the mean value in the diameter of the dye spread was increased by about 28% after the balloon decompression. The spreading volume of the contrast dye in the entire intervertebral foramen increased to a mean value of 98%. With this research at hand, it is positive to say that the area of the stenotic intervertebral foramen can be expanded by balloon decompression. The procedure of the sham group is very similar to the one using rods or epidoscope catheter in the aspect of being inserted in and out of the intervertebral foramen, so-called neuroplasty. Nevertheless, the significant improvement shown in the balloon group compared to the sham group indicates that balloon decompression might be more effective than other conventional neuroplasty. Based on the effectiveness of balloon decompression, a newly upgraded catheter called the Jin Woo was developed. It was designed for the balloon to expand according to the amount of dye injected. By using the balloon, you can try to remove a broader adhesion area and alleviate the stenosis in the intervertebral foramen and vertebral canal. I'd like to tell you about the clinical application of the Jin Woo catheter. The guide needle has to be placed parallel to the caudal epidural space. After taking the epidural, you can insert the Jin Woo catheter to the pathologic area for decompression and adhesiolysis. Most procedures are very similar to epidoscopic adhesiolysis, except for using the balloon. When the patient complains of severe pain. Second, do not balloon for more than 5 seconds. Third, the procedure is a repetition of ballooning, deballooning, and moving. And lastly, move the catheter in the deballooned state. This is a case that I performed on a female with right L5 foraminal stenosis, showing right L5, S1, and anterior epidural space filling defect. I performed the balloon decompression on the right L5 foramen and DRG area. As you can see from the spread of dye, the filling defect was resolved after the balloon decompression. The filling defect of anterior epidural space was also resolved after the balloon decompression. Even in post-spinal surgery patients, the use of Jin Woo catheter allows for safer and more effective adhesiolysis. I labeled common adhesion and stenotic area in circles. You have to focus on these areas when performing the procedure. I recommend you to perform on both sides of anterior and posterior epidural spaces in the case of central adhesiolysis. Entering the intervertebral foramen is very important. These are two methods to enter the foramen, the superior approach and inferior approach. The superior approach is to enter through the upper side of the foramen. The inferior approach is to enter through the lower side of the foramen. The left image shows an inferior approach on L5 foramen. Right image shows an superior approach on L5 foramen. I think the superior approach may be more effective than inferior approach because the spinal nerve runs through it and is the common site of adhesion. In central adhesiolysis, you have to expand the balloon at the retrodiscal area. We performed this prospective study with the Jin Woo catheter. We performed the balloon procedure on all kinds of refractory spinal stenosis patients. We followed up on all the parameters for a year. Both back and leg pain improved continuously over a year. ODI and global perceived effect scale also improved throughout the year. Compared to the other non-surgical interventions, whose effect tend to be reversed after 3 months, all of the parameters in this procedure continue to improve even after 3 months. I got the 3D image of balloon decompression before and after the procedure using the Jin Woo catheter. Here is the area of intervertebral foramen. You have to see, you can see that the dye spread better after the procedure. The main effects of balloon dilation using the Jin Woo catheter are as follows. First, claudication may be improved by marginal space expansion. Second, the re-adhesion rate is lower with more effective mechanical detachment. Third, improved working ability may facilitate spontaneous disc resorption. Indications to recommend balloon dilation include claudication, where radiculopathy caused by moderate or mild stenosis, perineural adhesion caused by chronic degenerative disc disease, short effects from other conventional interventions, which last less than 1 month. In spondylolisthesis, the short D effect is very good, but the duration of effect tends to be short. It's hard to predict the outcome in a multilevel severe spinal stenosis, post-lumbar surgery syndrome, and neuropathic pain. Balloon dilation using the Jin Woo catheter is the world's first non-surgical stenosis decompression. It was approved by the Ministry of Health and Welfare in 2013 in Korea after being certified by the NECA as a new medical technology. A new balloon catheter called the Jin Woo S was designed to be used with an epidural scope. This year, a new balloon catheter called the Jin Woo F was designed for transforaminal balloon decompression. This device is suitable for single-level and localized foraminal lesion. The medical evidence and effectiveness of this procedure were explained in a previous slide. Let me introduce the clinical application of the transforaminal balloon decompression using the Jin Woo catheter. You can try this procedure for most patients who have radiculopathy, which was not improved by an epidural block. I will explain the insertion method through the safe triangle. The red spot is an insertion point. The insertion point is actually in the inferolateral area of the foramen in order to place the needle as flat as possible. The red arrow indicates the direction of needle insertion. I advise inserting the needle close to the pedicle. Other than this, the rest of the procedure is similar to a transforaminal epidural block. If you are sure that the needle tip is in the intervertebral foramen, you should try to find the best direction and depth of the needle tip for a smooth insertion of the catheter, while inserting other epidural catheter before using the Jin Woo F catheter. When you find the best position of the needle tip with other epidural catheter, you can insert the Jin Woo F while holding the needle still. The catheter should expand just about 2 to 3 centimeters past the needle tip. You can confirm the catheter's position with the guide wire. Ensure that the balloon portion of the Jin Woo is in the epidural space. You have to remove the air from the catheter and fill it with contrast dye, as shown in the right slide. Then connect a 1 cc syringe on it, filled with only 0.1 cc of contrast dye. You have to withdraw the needle from the foramen before starting balloon expansion, so that you can perform balloon decompression up to the extraforaminal area. First, Jin Woo catheter should reach the central area. Then decompression is achieved through repetitive ballooning and deballooning the whole intervertebral foraminal area, including the extraforaminal area, while slowly withdrawing the catheter. If the needle tip is too close to the balloon, you have to withdraw the needle a little more so as not to damage the balloon. After balloon decompression, you have to remove the catheter and reinsert the needle to a previous epidural site in order to inject the drugs. I labeled the typical pathologic area where the Jin Woo catheter can work: L5 foramen, L5 preganglion area, L5 retrodiscal area. Kinds of catheter insertion. One is the safe triangle approach, another is Cambin triangle approach. Differ in the direction of the catheter placement. The direction of the safe triangle approach, shown in purple, is similar to the spinal nerve root pathway. However, the direction of Cambin triangle, shown in blue, is a little different from spinal nerve root pathway. I believe that the safe triangle approach is better because the pathologic site is usually near the spinal nerve root. Of this procedure using the Jin Woo catheter, simple and effective procedure for localized pathology in the periforaminal and foraminal area. Shorter and less painful procedure. Short learning time and less radiation exposure. High success rate due to the short distance from the skin to target foramen. Interlaminar approach possible. Target patients for the Jin Woo and the Jin Woo procedures are different. The transforaminal Jin Woo is best used for localized intervertebral foramen procedures. It's difficult for preganglion, retrodiscal, central, and multilevel procedure. The caudal Jin Woo can be used for intervertebral foramen, preganglion, retrodiscal, central, and multilevel procedures. So, if the patient has more than just intervertebral foramen problems, I'd recommend choosing the caudal Jin Woo catheter. This is the last slide. Thank you very much.